incident Singapore cardiac society, immediate past president of Asia Pacific Society of Interventional Cardiology, that is APSIC, founding member of Asia Interventional Cardiology Therapeutics. He is a great clinical researcher, teacher, and faculty. Professor Tan is an active clinical researcher. He is regularly invited lecturer and faculty in many international cardiology meetings. We know everybody. He is a visiting professor in China and University of Mandalay and Myanmar. A great human being. Like me, I'm very much fan of Professor Tan. Lots of Bangladeshi fellows, faculties, he loves Tan because he's a great human being. He's a great clinician, teacher, and cardiologist, but above all, he's a great human being. IPDI wishes his healthy and long life. Welcome, Mr. Tan in Bangladesh. Thank you, sir. Professor Abdul Wadud, sir, please introduce him, our faculties. Sir. Lots of faculties, please introduce him.
Professor Cheem, I think you know most of our faculties. My teacher, Professor Abdullah Al-Shafi, who is the General Secretary of Bangladesh Cardiac Society, and he is ex-director of National Institute. Professor Abjadul Rahman is also an ex-director of NICVD. Professor Mahmood as professor in NICVD. There is also Kaisar Nasrullah. They are working in two renowned private hospitals, and many others. Professor Shahabuddin, he is the head of the Department of Sylhet Medical College. Many other faculties are there, and some other are waiting to, they'll be joining shortly because their people actually could not finish their work. So, Professor Tan Cheem, we are really grateful that you have consented to give a lecture to us. And the subject is very important for the fellows. And if they have a good grounding in what to do, particularly in a complex case like bifurcation lesion, that will be very helpful when they become very active. COVID is not going to stay for long, and they have to go back to the cath lab and provide good service to the patient. To that end, I hope your lecture will do a great service. I now ask you to start your lecture. Thank you, sir.
Thank you very much, Professor Chowdhury, for the very kind introduction, and also Dr. Musid Ahmad for making this possible. It's an honor and pleasure for me to be involved in this interactive professional development initiative. Always been devoting myself to education of the younger doctors. I'm just glad to be able to share this with our Bangladeshi colleagues as well. So the topic that has been assigned to me is this step-by-step manual for planning and management of bifurcation lesions. So what is coronary bifurcation? It refers to a lesion that occurs at or near a division of a major coronary artery. And that coronary bifurcation is characterized by three important anatomical segments: a proximal, a distal main vessels, and a side branch. And along that,
please everybody mute. Please everybody mute.
So the thing about bifurcation lesion is that pathological studies have shown that the arterial branch points are foci of low shear and low flow velocity, and these sites are predisposed to the development of atherosclerotic plaque, thrombosis, and inflammation. And so the bifurcation PCI is considered in a high risk lesion. It accounts for 15 to 20% of PCI. There is considerable variations in the anatomy of the various bifurcation lesions, particularly important in left main bifurcation lesion. The plaque burden and location of plaque is highly varied, and the angle between main vessel and side branch are also very varied. And then we know that in the course of intervention, dynamic changes in the anatomy can occur. Plaque shift may happen, dissection can occur as well. And oftentimes in the intervention for bifurcation lesions, we have difficulty in achieving a perfect lumen reconstruction. There's either incomplete coverage of the ostium, and also all this result in an increased risk of restenosis. So no two bifurcations are identical, and appropriate very outset is important, and it helps to save life and to minimize complications. So this is the evolution of bifurcations PCIs for many of us who have been around for a long time. In the early days, there's not much of option except for kissing balloon inflation. And we started off with a bare metal stents in the early 1990s, going on to a DES in the early 21st century, going on to a second generation DES and so forth. Along the way, we come up with techniques of gel wire, provisional side branch stenting, port, final kissing, and DK crush, which has been around since 2010. So it's been about 2004. So it's been about 16 years since they've been doing this DK crush. So I think many of us know about there's many classifications. There's so many classifications that we had to deal with in the very beginning. But I think most of us have now settled with this Medina classification. And Medina classifications basically codes 3 numbers. The first number refers to a proximal main branch. Second number refers to the state in the distal main branch. Third number refers to the side branch. And it gives a number to either 1, which indicates the presence of stenosis, significant stenosis, or 0 for the absence of stenosis. So you get the 3 numbers. A typical true bifurcation will be a 1-1-1, where you have narrowing in proximal vessel, distal main vessel, and the side branch. However, all the classifications have a problem. The classifications depends only on angiogram. And we know that the angiogram is very poor in terms of telling you for sure how the plaques are being distributed and the extent of the disease. Oftentimes, you will need imaging to gather this sort of information. And this classification, which includes Medina classification, does not really take into account what happens to a side branch when you dilate the main branch. It doesn't have this predictive ability to tell you whether it is safe for the side branch or not. So in an intervention of a bifurcation lesion, I think there are unique challenges. And so these are some of the challenges that we encounter. We will have to deal with the discrepancy in the diameter between the proximal as well as the distal vessels. There are procedural complications that we have to deal with. Plaque shift that can cause a closure of the side branch, dissection, perforation, and sometimes even movement the artery during cardiac make the procedure highly challenging. There's considerable variations in the bifurcations and lesion anatomy, as I've mentioned: side branch patency, plaque distribution, lesion composition, angle between main branch and side branch, and the locations of the affected vessel. These are the other multiple challenges in bifurcation PCI, broadly classified into 2: clinical anatomical variations and procedural options as well. So just imagine you have to think about all this stuff as you consider your strategy, and you have to think of all these possible strategies that you can undertake in doing a PCI for this bifurcation lesion. So I think the approach to bifurcations PCI for particularly the junior doctors is that most of us would adopt what we call a provisional approach, and it is the most recommended approach. And the approach here is really dictated by the side branch. We need to know whether this is a true or not a true bifurcation. What is the size of the side branch, the extent and distribution of disease in the side branch, how important the side branch is for the patient and for that specific anatomy, and the angle from the side branch. So I think the provisional approach versus two-stent approach has been tested in many earlier randomized controlled trials. And so if you can see on the left here, these are the various trials that compare a provisional approach versus a two-stent or systematic two-stent bifurcation stenting approach. And when you look at the primary endpoint, actually most of them has got no significant difference whether you do a provisional or two-stent. In fact, it suggests that maybe a provisional approach is a safer option compared to a two-stent bifurcation strategy. When we follow up Nordic and trial for up to 5 years, in fact, you can see that the provisional approach seems to have a lower long-term mortality than the systematic dual stenting technique. But is this correct? But you must remember that this is still a very old data that we are looking at, and old techniques and so forth. So just looking at individual trials is not good enough. Let's look at meta-analysis of 5 randomized controlled trials, 7 observational studies, nearly 7,000 patients, and look at provisional versus two-stent strategy. And you find that actually provisional strategy seems to be safer with regard to DES thrombosis and myocardial infarction. There were lower incidence of thrombosis and myocardial infarction when you use a single stent strategy. But this is one meta-analysis, because when you compare another meta-analysis of another group of trials and patients, you find that in this study, two stent strategies are just as good in terms of target lesion revascularization and stent thrombosis and myocardial infarction and side branch restenosis. So the verdict is really not out here. We don't know whether provisional is really that good and so forth. But I think as far as clinicians are concerned, when you encounter a bifurcation lesion, there are only 3 choices that you have to decide. One is to just keep the side branch open and do nothing about it, just maintain it open. 2 is to do a provisional stent. In case the side branch gets into problem, then I deal with it. Otherwise, I leave it alone. 3 is to go straight for a two-stent strategy. So these are the basic 3 choices that we have to make. I think in the first strategy of just keeping the side branch open, this will be the situations when you have a side branch that is small, that has got osteo or diffuse disease, and is clinically not relevant. So we just simply want to keep the side branch open, and we have no intention of putting stent or something or anything else more aggressive in this sort of situation. So the techniques really is quite simple. You just in both the branches, dilate the main vessel, and then after that you stent the main vessel and you leave the wire in the side branch, and you pull the main vessel stent, and then with the side jerk wire inside in the side branch. Most of the time, there's no problem in pulling back the side wire from the side branch, and then you just simply keep the side branch open with this side branch wire. Provisional stenting is the next strategy. In provisional stenting, we use it when patient has perhaps a side branch that has minimal disease or only at the ostium, and when the side branch is suitable for stenting. So the technique here is you insert a wire into each of the main vessel and the side branches. Then you stent the main vessel with a diameter sink to the distal main diameter. Then afterward that you do a proximal optimization technique where you dilate the proximal part of the stent, and then you do a guide wire exchange. So you can actually take out your jerk wire, and then or you can take your main wire and then put it into the side branch, or you can take a new wire and go into the side branch. Jerk wire carefully to avoid abrupt guiding catheter intubation. So you pull the wire, the guide catheter may be sucked in, and then kissing balloon inflation if you want to do a kissing balloon inflations. Otherwise, the procedure pretty much ends with this provisional stenting approach. So some people want to do a routine kissing balloon inflations after stenting of the main vessel. Many of us do not necessarily do so. So provisional stenting has got advantages. It is very simple and it's very fast. It's got excellent short-term and long-term results, as I said before. It's got perhaps in their meta-analysis suggested a better long-term mortality even. It reserves all other options. So I can still do a two-stent strategy if my provisional stenting approach fails. And more than 60% of the left record can be treated using the provisional technique. So what are the lesions that we will select to do a provisional approach? I think most of us will favor insignificant stenosis at the ostial circumflex when you have a Medina classification of 110 or 100. You have a small circumflex of less than 2.5 millimeter. You have a diminutive circumflex, which you don't really want to intervene too much. When you have a very wide angle between circumflex and OA, and you have no concomitant disease or only focal disease in circumflex. So all these lesions would favor a provisional stent approach. Now, when we do bifurcations PCI, we have to consider the difference in terms of the diameter of the main vessels versus the distal vessels and the side branches. In general, we all know from the Finnish law or the Murray's law or whatever law that you come to know about, the main vessel is always going to be larger than the individual side branches, and the main vessel is typically two-thirds the size of the sum of the diameter in the two daughter vessels. So two-thirds, so this must be always larger in individually too, and two-thirds of the size. And this is important because we oftentimes will encourage people to do proximal optimization techniques for the reasons that you want to achieve good appositions in the vessel, particularly in the main vessel. So when you do a port after putting a stent across a bifurcation lesions, while your distal parts may be well expanded, the proximal part is severely underexpanded. This is where you do take a larger size balloon and you do balloon inflation in the main vessel in an attempt to fulfill the Murray's law, as we know that the main vessel is going to be larger. At the same time, it allows the reconstruction of the initial physiologic anatomy of the bifurcation. And by doing a port, it allows your wire to go in and out of the side branch quite easily. So why do we do port? We do it to correct any under expansions in the proximal vessel. You restore the proximal main vessel circularity. You facilitate the side branch rewiring, and you scaffold the side branch osteum with this port technique. Now, just a little bit on the port technique here. This is a technique that where you would actually put the distal marker just proximal to the carina. So take a short non-compliant balloon, put the distal marker at the carina so that you won't go too far off and go too distally and cause a rupture of the daughter vessel. All right. And so when you want to, after port and you want to access the side branch again, you will always direct the side branch through the distal strut of the stent in the main vessel. Now, this guide wire exchange where you want to access whether proximally or distally is quite important. Because if you access a patient's, if you access the stent cells which are proximal in the location, you find that you actually create carina in the daughter vessel. If you go by the distal cells, you actually provide a scaffold of the side branch, which is much better, which is much in terms of rheologic, the blood flow, compared to if you go by the proximal stenting. So for all intents and purposes, most of the time we will recommend going by distal cell, except for DK crush technique, which we'll talk about afterwards. Kissing balloon, another important part of bifurcations PCI. We do kissing balloon basically to modify the geometry of the implanted stent. We want to improve the expansions in the proximal main vessel. You want to improve also the result in the side branch. Typically, we do use two non-compliant balloon, and the size of which will be sized to the distal vessel and not the proximal vessel. But you can always have a short proximal overlap in putting the two balloons into the main vessel here. All right, so this is kissing balloon inflation. Most of the time, again, we will do what we call a two-step kissing balloon inflations. That means I inflate the balloon one time at high pressure, come down, inflate the balloon a second time, high pressure, come down in the side branch, and then both going up at a nominal pressure at the same time. So this is what we call a two-step kissing balloon inflation instead of just doing inflating both at the same time in what we call a one-step kissing balloon inflation. Some people don't like to do kissing balloon inflation. Then you can do what we call a port side branch and port technique, which is an alternative. Meaning to say that what we do here is keep the same as balloon inflation. You want to optimize the final result of a provisional bifurcation stenting. You want to maintain a circular geometry. You reduce a side branch osteum obstruction and reduce the risk of a side branch occlusion. So what do I mean by ports, side branch port? Meaning to say that you put a stent in the main vessel, you do a port, then you put a wire into the side branch, then you do another side branch dilatation, then you take out the balloon, and then you finish with another port. So in this case, then you don't have to do a full balloon inflation at the same time. So this is another technique that you can consider if you don't want to do a port technique. Now, provisional approach has got situations in some cases where you might have to go on to put in a second stent as in a build-up or a rescue two stents strategy. It all depends on the series that you are looking at. If you look at the Colombo study, well, 30% of its cases go on to do a two-stent strategy. But if you look at Pan and Stegen, you find that the crossover is actually very low in provisional strategy that was decided right from the very beginning. So when do we consider putting a stent into the side branch in a provision? I think all of us agree they have a significant side branch flow impairment, which is TIMI of rate of less than 3. We will consider some kind of rescue stenting if the side branch is large enough. In the presence of a major side branch dissection where you worry about acute abrupt closure, when the side branch is diseased and large enough to lead to significant residual ischemia after stenting of the main vessel, and where future access towards the side branch may be important to the patient, then you might consider a side branch stenting. So when you decided on a side branch stenting after putting a stent in the main vessel, you are basically, you still have 3 options in terms of bifurcation techniques. You can do a tap technique, you can do a reverse crush technique, or you can still do a keloid technique. And all of them have their own respective advantages and disadvantage, which I'll talk about again later on. But this will have been the build-up two-stent strategy. Now, the third choices in the bifurcation PCI is a two-stent strategy, where from the very outset, you have decided that you want to do two-stent strategy. And two-stent bifurcation technique occurs in between 15 to 30% again of our bifurcations PCI. And it's usually considered when the side branch is large, with more than 50% stenosis extending more than 5 millimeter beyond the side branch osteoid. And typically, the technique that we use is often one where you stented first and then followed by the main branch in a keloid and so forth. So that will be the technique that most of us would use first. So deciding which two stents approach, you can roughly use this table for your own purpose. Now, first of all, when you look at the anatomy, you ask yourself, are you comfortable and confident in rewiring the side branch after putting a stent in the main branch? If you're not confident of rewiring the side branch, then maybe you just go straight to a DK crush. If you're confident of doing crossing the side branch after a main branch stenting, then look at the anatomy first. Look at the angle between the two daughter vessels. If the angle is more than 70 degrees, you can try a T-stent or tap technique. But if the angle is less than 70 degrees, then you want to ask yourself again, is the main vessel and the side branch are of the similar size? If the main vessel and the daughter vessels are of different sizes, then perhaps a DK crush or tap technique is better. But if the daughter vessels are about the same size as the main parent vessel, then you can do a tap or crush or keloid stent technique. So when you have a large discrepancy in the size of the main vessels and the daughter vessels, keloid is really not a good choice in that sort of situation. This table, and you can see keloid branch is about the same as the diameter of the main vessel, less than 55 degrees, and you can actually do a brush, and for you have to just put in the two stents right away. When the angle is less than 90 degrees, you can use DK crush in any sort of bifurcation. It's about 90 degrees, then perhaps a T-stent or a tap technique is more applicable. So my strategy here is that as an operator, you should know at least one or two types of two-stent bifurcation techniques. And I always think that it's going to be anatomy driven. So if the angle is more than 70 degrees here between the two daughter vessels, you can consider a tap technique, which is what I will do. If the angle is less than 70 degrees, then I will do a culoid or a crush or DK crush technique. The T-stenting strategy here. So when we do T-stenting strategy, you basically put your stent in the main vessel, and then you maintain the wire in the side branch, and then after that you cross into, once you put in the main vessel, you go to the side branch, you balloon, pre-dilate, and then you put in your second stent, what we call a T-stent technique. So it's used to optimize the side branch stenting, and there is a modified version of T-stenting called the tap technique, and that you will want to access the side branch through a distal strut. So I want to say that T-stenting strategy, while it is actually a good strategy, one of the biggest problem is that when you put a stent in the side branch, very often you may have a situation where you just about miss the ostium of the side branch, which can be a site of a focal restenosis, as in this particular case that is illustrated. So then people come out with a better strategy to avoid this missing covering of the ostium of the side branch, is what we call a tap technique. The tap technique here is by the Korea that with a side branch that is jailed in the side branch with a guide wire that is jailed in the side. Then after you perform, you will put your worry about that protruding part, whether you'll be crushed, whether it will be deformed, and so forth. This is a bench testing that tells us that the kissing balloon to post-dilatation does not crush the side branch stenting technique. And tap crush and because that technique. Let's look at culoid technique. Again, culoid is something that is very familiar to many of us. First of all, you will dilate both branches. Then you put the stent into the more angulated side branch first. And once you put in a stent, then you withdraw the wire and pass it to the other main vessel, do a balloon pre-dilatation, and then put in your second stent. And then at the end of which, you will cross the wire again with the first into the first stent, and you do a kissing balloon inflation to finish the procedure. So culoid was first described by Chevalier and way back in 1998, so that's a long, long time ago. So the advantage of culoid is that it allows adequate ostial coverage both in the primary two-stent strategy and also as a provisional technique. So the thing about a culoid is that proximal vessel, which is the parent vessel, have double layered sleeve of stent. This is the biggest contrast to DK crush, where you only have a multi-layer of stent on one side of the vessel, not the entire sleeve of the parent vessel. Both the proximal end of the main branch and the side branch stents will need to be sized up to the proximal vessel. That's why the discrepancy cannot be too large. And both main branch and side branch, as I said, need to be similar in diameter. And you want to have a stent design that have a cell space that can be expanded to the size and diameter of the side branch. So this is a illustration of a patient with 111 Medina classification. So you can see that there is actually very tight lesions at the distal lamina and the osteo of the LAD and circumflex artery. And this is the spider view. Again, you can see that there is a severe stenosis, a true 111 lesion. What you do is you put a stent into the side branch first. And then this is a very important technique. As you pull back your wire from your side branch and direct it to the distal cell into the other main vessel, you want to make sure that you don't pull the wire out of the stent. So you know for sure that your stent, your wire is always within the stent in the proximal segment. All right. So now you direct into the main vessel, you do a balloon pre-dilatation, you put in your second stent, and then you do what we call a two-step kissing balloon inflation, dilate the main vessel, dilate the side branch, go up together, and then you finish with a port if necessary. So this is the finite angiography in this patient who had a keloid stent technique. And this is the IVUS study telling you that the stent is fully expanded in the post, and you find that there is a very round shape, so suggesting that there's very little asymmetry that we are looking at here. So the keloid stent technique has got an advantage, is that it provides a near perfect coverage of the side branch ostium. The disadvantage is that it has got a high concentration of metal with double stent layer at the coronal and in the proximal part of the bifurcation. You require rewiring of both branches, and you need both stents to accommodate the potential diameter mismatch. Let's talk about DK crush. This DK crush has become quite well known in recent years. DK crush is a 7-step procedure according to Dr. Chen Shaoliang. First, you involve a side branch stenting, then you take the balloon and crush it, balloon in the main vessel to crush it, and then you do your first casing balloon inflation, then you do your main vessel stenting, you do a port, then you do a second casing balloon inflation, that's why it's called a double casing, and then you do a final report. So this is a 7-step procedure. But the Dr. Chen from China, Nanjing, will tell you that DK crush is best supported with a 3 steps of IVUS or OCT imaging. Let me show you again one case. This is a patient with a clearly a 111 sort of a distal left main bifurcation lesion. After you have wired both lesions and pre-dil the lesion, you would suggest that we do a first IVUS to see. Firstly, to evaluate the pre-dilatation results. Then you want to size this side branch. You want to size the main branch. Notice where are the healthy landing zone, whether it's in the proximal or in the distal, and then you want to size the port balloon for the parent vessel. So this will be the typical images that you will get from a first IVUS imaging after pre-dilating both the side branches. So having done the imaging, you will put your first stent into the main vessel here. So he took a long stent, and then after that he took a balloon to which is sized to the LAD vessel to crush the stent. And then after that, you will take an even larger balloon to crush the proximal part of the stent within the left main. Vessel, and so you put the stents first, and this will be the stent results. And after which, we will always port it again in the main vessel. So you will port it in the main vessel, and this is the result. After you have done this, you will now have to recross into the side branch to do your second kissing. But in this case now, you would have to pull up your side branch wire first, and then before you do your stenting in the main vessel. So this is a 2-step kissing balloon inflation here and here. And then we finish with a port, and this is the final results. So then you should end your procedure with a third IVUS to look for your optimal stent expansion. And in mild apposition, make sure there's no edge stenosis, there's full lesion coverage, and there's no edge dissection. And so this will be the final IVUS findings, and this will be the angiogram after a DK crush technique. So this is 1 year follow-up after DK crush, still looking very good. So the DK crush technique advantage is that it's a very effective technique, very effective for large dominant disease, circumflex, definitely better than the classic crush, because in classic crush, 10% of the lesions you can't cross into the side branch after a crushing with a stent in the main vessel. The disadvantage is they cannot be performed as a provisional strategy. There are multiple steps involved and few operators may have the experience. So the outcome as far as DK crush and keloid stent technique is that we know that from a DK crush 3, looking at these two different techniques in patients with left main bifurcation, DK crush was superior to keloid stent technique. And the reason why it may be superior is because of this residual necking rings that we see in patients with a keloid stent technique. In the DK crush, there's no napkin ring residual, but in the keloid, you can see this napkin ring. Whether this is the reasons for the adverse outcomes, we don't know, but this is something of interest. But for sure, nowadays, when we decide whether we want to do one stent or two stent strategy, we can actually predict based on this definition trial. Definition trial has got a criteria that will tell us whether the lesion that you are dealing with is considered a simple bifurcation or a complex bifurcation. And you would define somebody as having a complex bifurcation if you have one of these major criteria plus two other minor criteria. So these two other minor criteria can be in any of the following. It could be the main vessel length of lesions, it could be presence of thrombus, multiple lesion, and so forth. So by looking at this criteria and testing it out in what we call the definition 2 trial, which was presented at EuroPCR eCourse this year, clearly a use of a two-stent strategy was superior to a provisional strategy when you are dealing with complex bifurcation lesion with regard to clinical endpoints of reduced target lesion revascularization and target lesion failure at 1 year. So now we can actually, instead of just eyeballing, we have objective criteria where we can rely on to ascertain whether a bifurcation lesion is indeed complex or simple. I want to end on by just commenting a little bit on the imaging guidance. I think IVUS or OCT will be very helpful in any form of bifurcations PCI, and that they will provide a better insight into the part configurations, which may actually help you to decide whether to do a two-stent or a single-stent strategy. And it will help to improve outcomes for sure and allow a selection of an appropriate stenting strategy. And certainly, it will also help in terms of aiding the vessel sizing and identify calcifications where you might consider atherectomy. In fact, the use of IVUS has been shown to even have a mortality benefit in the left main PCI, as in the report published by Korea. So IVUS is certainly something that you will encourage in being a complex bifurcations PCI, particularly involving the left main. The other thing about FFR, which I want to touch on here, is that oftentimes when you do a provisional stent strategy, you might find that there is a plug sheave or groinal sheave, which causes a narrowing of the ostium in the side branch. And Kood did a very important study to tell us that when you have a side branch osteal lesions of more than 75% stenosis, actually 2/3 of them are physiologically not significant. That means only 1/3 of patients actually do you have to worry about whether there's ischemia going on and so forth. So for the most part, if the patient has got no symptom, has got no angina, no ECG changes, and the blood flow is good, I would just leave the side branch alone if I've already decided on a provisional stenting strategy. And certainly when you use FFR, it has been to decide whether to leave the side branch alone and consider a provisional approach or deferred strategy and so forth. It has been validated in at least 4 clinical trials. So FFR-guided revascularizations can be safely applied to patients with bifurcations or left main stenosis. And we know that these bifurcations lesions can be assessed quite accurately if there's no downstream significant stenosis. IFR has not been used to evaluate a bifurcation lesion at this point in time. So in conclusion, Mr. Chairman and everybody, all my friends here, I think the goal of PCI in bifurcation lesion is to attain optimal results in the main vessel and to maintain the physiologic patency of the side branch. The planning of the strategy upfront is critical, and knowledge of all possible BOR techniques must be kept in mind. You must have at least two stent strategy up in your sleeve as you consider complex bifurcation PCI. So while the provisional side branch stenting should be the default strategy for low-risk bifurcation, a two-stent technique may be preferable for high-risk or true bifurcations. Although evidence is lacking as to the superiority of one two-stent technique versus other, I personally feel it is unlikely that any single two-stent technique will be superior in all bifurcation morphology. Depending on your own preference, DK crush technique seems to be the most favored, but tap technique and keloid techniques are also excellent options, in my opinion. The decision as to which two-stem strategy to use should be driven by the bifurcation morphology, the operator experience, and the clinical trial data. And finally, employing imaging as well as physiologic assessment plus atherectomy to save time and optimize accounts will be something that I would highly encourage. Thank you very much for your attention.
Thank you, sir. Thank you, sir. Excellent presentation, sir. I think all the panelists and participants will enjoy it. This you lecture in the archive, in the IPD archive. I think all the junior fellows also learn a lot at the evening or night time when they are relaxed. Thank you, sir. Professor Abdul Rahman, sir. Professor Abdul Wahid Chaudhary, sir. Professor Abdul Wahid Chaudhary, sir.
I think one of the beauty of this lecture is he did not make things complicated. From a very simple viewpoint, he started and then go into detailing what to do. And the technique of doing one step after the other, that's the way of doing things. You have to have a very clear idea what you want to do. And always when you want to do bifurcation stenting, particularly in left main, you should not do it at an ad hoc basis. It's better to have a very pre-planned arrangement of everything at hand so that you can actually go ahead without any complication. Thank you, Professor Tan Shahim. It's a very nice and detailed lecture, and it will be very helpful for the junior colleagues.
Thank you, sir. Thank you. One of the experienced operator and organizer, Professor Dr. Abdul Rahman, sir, with us. Please, sir. You like bifurcation always. You love bifurcation. Please, few comment regarding the lecture, sir.
Yes, Professor Tan, thank you. This is a very brilliant lecture, I would say that, because you pinpointed the thing rightly and you make the thing very simple. The way you are dealing, that's really appreciated. So I personally like the provisional stenting, and most of the time, if you think like you, like what you do, most of the bifurcation can be dealt with the provisional stenting, even 80 to 85%. So only 5-10% or 20% cases you need a double stenting strategy. And you have demonstrated that the several way of the double stenting strategy, either decay crash or mini crash or full or tap technique starting from the. But which technique you are comfortable? I think so. The operator should do that. If you are comfortable with decay crash, you should go for decay crash. If you are not comfortable with full, you should not go for the full. So starting of the full maybe you cumbersome. Another thing you stress, you give the impression that imaging has a role, especially in the setting of the double stenting strategy. But provisional stenting strategy, I think so, because in our country it is very difficult to cope with the financial problem. Is very difficult. So IVAS or OCT and in all that bifurcation is very difficult. And the people like you can do the complicated process even with the without imaging. That's right. Suppose you are a very expert. If I say that this is a decay crash, the left main, you should do it without imaging. Are you ready for do that or not? For you, not for me.
I could, but I prefer to use imaging.
Okay, that's right. That is the very and the recommendation is class 2A. So the expert like him can be done, but should we do with the image? And thank you, sir. Thank you for a great lecture.